A very warm welcome to everybody who's joining us for this webinar today. My name's Michelle Stanistreet. I'm the NUJ's General Secretary. Just a reminder for those that have joined that the captioning is available for anybody who needs it. We're very pleased to be holding this webinar. It's part of the union's ongoing work on building menopause awareness and ensuring that proper support and policies are in place in workplaces across the media industry. And very much key to that work is a clear understanding that the menopause is an equality issue. It's a workplace issue and it's absolutely a collective trade union issue. It isn't something that should be dismissed as a private matter or as a women's issue. It's something that should absolutely be discussed openly and taken into account in the design of workplaces and working practices. And whilst we've seen recently a very welcome uptick in the amount of proactive campaigning and press coverage and general awareness raising of the menopause and perimenopause, we know all too well that there's still a good way to go in ensuring employers are doing all that they can for their staff and freelancers, and that's absolutely the case in our sector across the media industry. There was a recent survey by the TUC that I think really underlined the kind of need for this work. It showed that many women are still reporting encountering sexist and ageist attitudes and practices towards women, the menopause and female ageing more generally in their workplaces. And I know that when we come on to Helen and Claire, who I'll introduce properly shortly, they'll also kind of reference the recent research by the Fawcett Society too. And in the TUC survey of those women with direct experience of the menopause, a massive 9 out of 10 felt that the menopause was adversely affecting their working life. Almost a third of them felt that the menopause was treated very negatively in their workplace. And 6 out of 10 reported witnessing the menopause as being treated as nothing more than a joke, with many more reporting that they'd been penalised for their menopausal symptoms by performance management or through sickness absence policies. And we know in the kind of day-to-day work that we do as a trade union that women have lost their jobs when a simple adjustment to working conditions at the right time would have sorted things out. Many more have been left floundering to such a degree that they've just felt simply unable to carry on and have quit their jobs altogether. And what a loss, a monumental loss of skills and of experience that represents. And as we're beginning to see now with cases of menopause discrimination flowing through and appearing at tribunals with some very satisfying tribunal wins for those women failing to act, we'll also see increasing numbers of employers facing costly and damaging litigation. So really doing nothing shouldn't be an option anymore. And we know that, like so many of the issues that we face in workplace, there are loads of things, lots of ways in which this problem can be addressed and improved. Things that employers should be doing because they've got a basic duty of care, but also things that will benefit them organisationally as well as impacting favourably on their female staff as individuals. And there are loads of great initiatives around working to tackle what has been a taboo. The TUC has an interactive guide and a training module, which is a great resource. The reps guidelines and template policies are things that we've made available through to all of our reps in workplaces, and our officials work very closely with those policies. But we want more workplace policies in place. We want employers to offer quality information sessions like this one, and we want to encourage more employers to make available and fund access to specialist menopause care and medical advice and treatment as well. And it's as part of that work that we're really pleased to be holding today's webinar, which has been made possible by Dr. Claire Spencer and Helen Normoyle, who together run a brilliant organisation called My Menopause Centre. Claire and Helen recently came along and gave an excellent training session to NUJ staff and officials, a really thought-provoking session, and there's a huge amount of useful information and graphics on their website that's definitely worth a look, mymenopausecentre.com. So we're really pleased to take up their offer of a webinar that we can now make available to our wider membership and reps network as well. As part of today's session, there'll be plenty of time at the end for where we can address any questions that you might have. If you do have any questions, can you pop them please in the Q&A box rather than in chat, and we'll make sure we spend time and go through those at the end of the session. So I want to say to Claire and to Helen a very warm NUJ welcome, and I'm going to hand over to you both now.
Thank you. Oh, Helen, you're muted.
Claire, after 2 years, 2.5 years of doing this, you think I'd crack this by now. So thank you, Michelle, for that very warm introduction. Dr. Claire and I are delighted to be here with you today. We thoroughly enjoyed the session that we did with you at the end of March. It was also the first live session that we'd done coming out of COVID. And we hope that everyone will enjoy today's session as well. So Claire and I founded My Menopause Centre. We have been talking about launching for 4 or 5 years, driven off the back of Claire's professional experience, my personal experience, not great as you can imagine, of menopause. But we've been friends for about 10 years. Our kids went to school together. And in today's session now, if you just bear with me while I share my screen, and hopefully that will be up in a moment. Right, can everybody see that? The screen up there? Yeah, fantastic. So in today's session, we're really going to focus on demystifying the menopause. We hear the word bandied about a lot, but there's still a lot of people who don't really understand what it all entails. And the purpose of this is to really help women and help others help women and others to thrive in love, life, compassion and work. And as Michelle said, the presentation will take 20 to 25 minutes. So we've left lots of time at the end for the questions, any questions that you might have. Now, before we kick off, as we go through the presentation, you'll see that we use the terms woman, female and her. However, we are very inclusive and supportive, however people identify, and recognise that people from different communities can also experience menopausal symptoms as a result of hormonal changes. So for example, some trans men, some non-binary people, if you're undergoing fertility treatment or if you're having hormonal treatments or illnesses for certain conditions. So we've put this in bright orange to really emphasize the point. As Michelle has said, it's absolutely time to kickstart the conversation around the menopause and to reframe attitudes. And the reframing of attitudes is so important when it comes to tackling the ageist and sexist stereotypes that exist beyond and intertwined with the taboos around menopause. Now, it's really important because menopause is not a niche issue. It's not something to be discussed in a quiet corner of a room. And why is that? Well, if we look at the number of women across the UK today who are in some stage of the menopause transition, that equates to about 15.5 million women. Claire will speak about the stages of the menopause transition in just a moment. So the perimenopause, menopause and postmenopause. And if you're joining this call from Ireland, that equates to about 900,000 women in the Republic of Ireland as well. So this is a mainstream issue. It's a shocker that it's still a taboo issue. And it's a shocker because of the stigma and because of the taboo around it, there are real life consequences for women. In some research that we conducted last year with a brilliant outfit called Britain Thinks, we found that 1 in 4 of the menopausal women that we interviewed feel or felt prepared for the menopause. Around half of them underestimated the physical symptoms and half underestimated the emotional symptoms. And again, Claire will cover this comprehensively in just a moment. In research conducted by the British Menopause Society, half of the menopausal women interviewed said that menopause had a significant negative impact on their home life. A half said that it had a significant negative impact on their sex life. 4 in 10 that it had a negative impact on their work life, and we'll cover that some more towards the end of the presentation. And 3 in 10 a negative impact on their social life. So these are very sobering statistics, I think. And yet, despite all of that, in that same British Menopause Society research, 1/3 of the women interviewed responded and said that they didn't take any action. Now, there are a variety of reasons for this. It could be because of stoicism. They felt that their symptoms weren't bad enough in order to warrant taking any action. They felt that there was nothing that could be done to tackle their symptoms. There was, for some, a reluctance to use HRT because of what they'd heard about it. And for other women, yet there was real embarrassment to speak to their doctor about some of their symptoms, particularly those that are related to urinary issues, vaginal or sexual ones. So this, I hope, really reinforces why it's so important that as we're doing now, we're having these conversations, we're normalizing the conversations, because in that research we did with Britain Thinks, we also saw that knowledge really is power. Women who felt prepared for the menopause transition tended to cope better and feel more positive. So that's really what the bars on this slide are showing. So more women were far more likely, twice as likely, to agree that menopause can be a positive change in a woman's life than if they were prepared for the menopause than unprepared. They were less likely to agree that they felt under pressure just to cope with the symptoms. They were less likely to agree with the statement they felt or feel more isolated. So knowledge is power. Sharing information about menopause symptoms, and really importantly, as Claire will cover in a moment too, what can be done to help support and to manage those menopause symptoms. And if we look at how life expectancy has changed within the last 100 years, we can see that we're spending almost 80% more of our lives post-menopausal as we would have done in 1922. So that's gone from women experiencing menopause slightly older at the age of 58 and average mortality rates at around 77 years to in 2022, we're experiencing menopause a little younger, so average age 51. And again, Claire will come to that. And the average woman can live now to expect to be around 89 years. So why on earth would you give up on the last 43% of your life? You're barely halfway there, really. And so that's why this moment in life, it's time to put yourself first, take stock of where you're at in life and really look at your health so that it's not just about having lifespan, it's about having health span. And so with that now, I'll hand over to Claire, who will thoroughly demystify the menopause for you.
Thanks, Helen, and good morning, everybody. It's lovely to be here. So the menopause actually means end of monthly periods, and it's defined as a point in time which is 12 months from your last period if your periods have stopped because your ovaries have stopped producing eggs. For most women, this will be a natural part of their lives, but some women will have a medical menopause as a result of chemotherapy or medication, and some women will have a surgical menopause as a result of surgery to remove their ovaries. And so if we just move on to the next slide and we see what that actually really looks like. What we're focusing on here is the orange line, which is an image, it's a depiction of estrogen production from our ovaries. And so if we start right over on the left-hand side, really the premenopause starts at puberty with the start of periods, where our ovaries rhythmically make estrogen, and the bottom blue line is progesterone, the little pink blob is a period. And so for most women from puberty, you'll have a normal, regular monthly period, and your estrogen will flow up and down with your progesterone in a rhythmical, predictive way. The start of the menopause transition, and it really is a transition rather than a point in time, is the perimenopause. And this is where the feedback mechanisms start to go a bit awry and you lose the rhythmicity of the hormones. So the estrogen production is really erratic. It can be high, it can be low the next day. And that big swing of estrogen can trigger symptoms itself, such as anxiety, such as migraine. And the nadirs are lower, so the sort of troughs are lower. So on average, estrogen levels are lower. And that's why many women start to experience symptoms in the perimenopause, which can start in your early to mid 40s and can last as long as 10 years. So, you know, this is a transition. This is a sort of continuum in time. The menopause occurs when your periods have stopped for a year. So you wouldn't have known that that last period was your last period. We can say you've been through the menopause when you look back, think, oh, yes, it was 12 months since my last period. and then you're straight away into the postmenopause. So you can see it is more of a transition, and that menopause is a fleeting moment. The postmenopause is then the rest of our lives, when the ovaries stop making estrogen and the levels stay low and permanently low. And this is relevant because symptoms can start early in the perimenopause and they can continue far on into the postmenopause. So, you know, I've got women in my clinic in their 70s and even 80s still having hot flushes. So if we move on to the next slide, we can see that around 8 out of 10, oh, go on.
Paula, Claire, sorry, can I just check? Paula has put a comment in the chat saying, are we meant to be able to see the slides? So I just wanted to check whether other attendees are managing to see the slides. We can certainly see the slides, and Natasha Brown has happily, okay, so other people can see the slides, that's absolutely fine. So hopefully, Paula, you can sort out whatever the issue is at your end. But that's reassuring. Thank you, everybody.
Oh, that's great.
In to say they can see it. Sorry to interrupt, Claire.
Oh no, that's okay. Can you hear me? I started worrying that I've been speaking on mute for 15 minutes.
No, we can hear you and see you great. Thank you.
Perfect. So as I was saying, you know, even though the estrogen levels drop after that fleeting moment that is the menopause, symptoms can linger. So 8 out of 10 women will experience symptoms, on average 7 symptoms. On average, symptoms will last 8 years, but can last 12 years or longer. And 20 to 25% of women in most surveys will experience those symptoms as problematic. So I hear a lot that women feel they're too young to be in the menopause. They can't be experiencing symptoms that could be menopause related in their early 40s, but you can see that you know, you can absolutely be experiencing symptoms in that age. If we just think what the symptoms actually are, so we sort of split them into different categories. So most people will have heard of the vasomotor symptoms, hot flushes and night sweats, which can be anything from being completely drenched at night, changing their bed covers, changing their pajamas, nightie, and you know, even cutting your hair at the back so you haven't got that horrible wet hair feeling on the back of your neck. Due to, you know, some women will just feel a bit warmer than they used to. There are physical symptoms which really relate to the fact that many women, you know, that estrogen receptors are important in so many parts of our body. Helen, if we just move the slide on, we can see that so bladder issues are really common as we have estrogen receptors in the bladder, in the vagina, which I'll come on to. Weight gain is incredibly common. Muscle aches and pains are an important symptom for many, with the knock-on effect that they may stop exercising, which compounds the weight gain issue. Obviously, changes in periods, they can move from being regular to nightmarish, heavy, horrible, or diminish into virtually nothing and just the odd period here and there. Headaches and migraine are common, palpitations, and then some less common symptoms that women often haven't heard of. So burning mouth syndrome, which can be really life-affecting, and changes of skin sensation, feeling of creepy crawlies, crawling over your skin, or itchiness, less common but very vivid, lesser-known symptoms. The psychological symptoms often take women by surprise. And so again, if we just move on with the slide, so low mood and anxiety. Helen, if you don't mind just clicking it on, sorry, I'm slightly out of order. Brain fog. The issue is that estrogen levels in our brain control many of the hormones that are responsible for mood and anxiety. So the overall dip in estrogen is responsible for a drop in serotonin, and the swings of estrogen can trigger anxiety. And so low mood, feeling of lack of motivation, that horrible feeling of walking through concrete that some people would describe, as opposed to many women will say that they're just sweating the small stuff. They're anxious over small things that they've never used to be. You know, they're anxious about driving the car on the motorway and in a way that they never would be. And then cognitive changes, because again, the brain needs estrogen to fully function and for different parts of the brain to speak to other bits. And so memory issue, word finding, can't think of that word that you're just trying to get on the tip of your fingers, are really common. And then symptoms relating to sex, and so vaginal dryness and itching can occur. The vagina can lose its elasticity, and so sex can become painful. And so this can result in a loss of libido, as well as loss of libido resulting from any and all of the above symptoms that we've spoken about already. And so you can see how vicious cycles of symptoms can be set up, where, you know, memory, word finding, poor concentration can really feed into the anxiety that's been triggered, all related to loss of estrogen. And many women feel, you know, this is my inadequacy, it's my personal failing, but it is not. It is really as a direct effect of those changes in hormones. And so we can see that there are symptoms that are going to most impact at work. It doesn't take much imagination to sort of see how difficulty concentrating, the issues with memory, feeling low, loss of confidence, that really stop women going for the next job, from taking the next step up, that are having a direct effect on women leaving work or thinking about leaving work, taking early retirement. That are responsible for many of the statistics that Michelle presented earlier, along with tiredness, lack of sleep, really quite debilitating symptoms that can affect many women. And then if we just think about the long-term health consequences of the menopause, so estrogen is also responsible for the functioning of our cardiovascular system. So without estrogen, the risk of heart disease increases to above that of men's after the menopause, whereas before the menopause, our risk of heart disease is below that of men's. Osteoporosis, which is thinning of bones, it's loss of bone density, it's increasing the risk of fractures, because estrogen is really important for maintaining bone density. And urogenital syndrome is the syndrome where there's vaginal dryness, soreness, bladder irritation, feeling like you've got a urine infection, but there isn't one, which can worsen if that's not treated, if it's not nipped in the bud. And it's so important to volunteer these symptoms because they are really easy to treat and get on top of. So we've talked about all the symptoms, you know, so what are the positives? What can we do about it to just get ourselves thriving as we transition through the menopause? Well, the great news is that there are many different things that we can do. And menopause care really is not one size fits all. There is no single magic bullet for most women. And it's often a combination of factors and, you know, tailoring care to a way to care that suits each individual most. So there's no surprise that lifestyle factors, so stopping smoking, reducing alcohol, increasing exercise, can all really help sleep. They can diminish menopause symptoms, and they can diminish the long-term health risks for women as they transition through the menopause. Sleep is really crucial. Trying to get enough sleep when sleep is affected by the menopause. So, you know, whatever it is that can help in terms of relaxation, in terms of learning breathing exercises. For many women, it will be meditation. Mental well-being is so important. Just carving space to sort of soothe your frazzled mind, I always think of it as. So as I said, for some women it will be talking therapies or yoga, speaking to others, you know, the sort of power of group conversation. Many women will find soothing alternative therapies, so acupuncture, Reiki, reflexology, you know, whatever you find helpful. And herbal remedies are used by some. You just have to be a little bit wary with some herbal remedies because they do have pharmacological actions. So, for example, St. John's wort interacts with many important medications. Black cohosh can gently push your blood pressure up. Sage also can have an impact. So you do have to be wary and just check other medications that you may be taking or other health conditions. And then there's medical treatments that are not HRT that can be prescribed by your GP or a menopause specialist, particularly if you've been advised not to take HRT or you don't want to take HRT. So clonidine is a blood pressure tablet. This is licensed to treat hot flushes also. Gabapentin can be helpful with sleep, pain, and take the edge off hot flushes. And some women do get value from antidepressants in helping psychological symptoms and helping hot flushes. If you can take HRT, then there is evidence that HRT is more effective than antidepressants, but certainly they do have a place to play. And then there is HRT. And I think it's really interesting now at this point that we're at in 2022 to look back at these headlines that we'll have all have seen around 20 years ago, where the results of a study, the Women's Health Initiative study, was published. It's sort of interesting to think about the dramatic yo-yoing of changes in attitudes to HRT comparing where we are today. You know, around 20 years ago, when the Women's Health Initiative study was published, indicating and highlighting an increase in risk of breast cancer, almost overnight, women stopped taking HRT and GPs certainly stopped prescribing it. There was a lot of anxiety surrounding HRT. With time, further analysis has shown that the risk is not as great as the sensationalized portrayal of the statistics that were first suggested, particularly when the absolute numbers were used and the risk of HRT was compared with more important lifestyle risk factors. And so now, you know, if we look at the headlines, it's fascinating to see the difference the year has made. There's been so much more in the media. And certainly where I'm sitting, I can feel a seismic shift in attitude and acceptance of the menopause and HRT, both in society and amongst women in the menopause transition also, with far more women coming forwards and asking HRT. And so as you can see, there have been HRT shortages to contend with as demand has really outmatched supply. The government have appointed their HRT czar. This slide summarises data from the Fawcett report, and this was a report produced by the Fawcett Society based on survey data of over 4,000 women, and it was commissioned by Channel 4, and this is the data that was used in the Davina programme, the second Davina programme. And this, as I say, was a survey of 4,000 women. Of the women in the sample who'd not tried HRT, encouragingly, the vast majority, so over 92%, had heard of it. And the survey, 14% of the women were taking HRT. And interestingly, this is still around a half of the numbers taking HRT before the start of the breast cancer scares of the late 1990s. So before the headlines that I showed on the previous slide. Around 54% of women at menopausal age using HRT said, brilliant, yes, it had given them their life back. You know, you cannot argue with that data. It makes a massive difference to many women. Of those who hadn't tried it, interestingly, so around a quarter still cited worries about the risk of cancer, other illness. A quarter said they didn't feel that they knew enough about it, so a lot to be done still surrounding education. And around a third of women cited low impact of menopause symptoms, which fits with previous data. So some women, you know, having a nice, easy ride of it through the menopause. And interestingly, if we then look at usage of HRT across different groups, you can see here, so affluence has an impact with the more affluent AB women taking HRT. There's variation with ethnicity that we probably haven't completely bottomed the reasons behind it, but certainly fewer Black and minoritized women taking HRT. And unsurprisingly, there were more women with more severe symptoms who took HRT than women with the milder symptoms. And so if we just think about the myths of HRT, so, you know, going back to that slide, we can still see there is still concern about HRT causing breast cancer. But as I touched upon, this risk is very small, and for most women less than the risk of obesity and drinking alcohol. So the next slide shows and summarises the results of the Women's Health Initiative study in absolute numbers. So you can see on the left the baseline risk of breast cancer, 23 cases per 1,000, diagnosed for women in their 50s over 5 years. If you look at the women whose body mass index is 30 or greater, so overweight or obese, that actually more than doubled the risk. So that was 24 additional cases to the baseline of 23 per 1,000 being diagnosed with breast cancer over 5 years. If you drink more than a glass of wine a day, on average, so that's 2 units of alcohol or a pint of beer, a double gin and tonic, 5 extra cases in addition to the baseline. And then there were 4 extra cases of women on combined HRT. Now, this was old synthetic HRT, and we have got data now showing that actually the numbers of women being diagnosed with breast cancer on the newer body identical types of HRT, where the hormones are identical biochemically to our own hormones, there is a lower risk than those 4 extra cases per 1,000. And 3 extra cases of women who are smokers. If you've had a hysterectomy, you only need 1 component of the HRT, which is estrogen. And actually, the women who took estrogen, there was little or no increased risk of breast cancer. You can see 4 fewer cases. And surprise, surprise, the women who exercise on average 2.5 hours a week, that reduced the risk of breast cancer also. So if we just go on and think about some of the other myths, you know, so hopefully we've addressed the breast cancer issue. There is a very small risk, which is related to how long you take HRT for. The risk is low with body identical hormones. HRT does not cause blood clots if you have the estrogen through your skin as either a patch, gel or spray. If you swallow estrogen tablets, it does double your risk. The risk is still likely to be very low, but if you are at risk of blood clots, better to have the estrogen through your skin. There is no evidence that estrogen causes weight gain. Weight can be gained through the menopause and with aging, but not because of HRT. Taking HRT does not press the pause button on your menopause transition. It's not delaying the inevitable. So when you stop HRT, you will feel how you would have felt anyway at that age. Herbal methods, as I've touched on, aren't necessarily more effective or better or safer. You know, they do have activity in the body. And there's no limit to how long you can take HRT for the vast majority of women. There is no arbitrary cutoff time. You don't have to stop it at 55 or 5 years or when you're 60, as long as you accept those small risks that for the vast majority of women will be outweighed by the benefits of reducing the risk of heart disease, reducing the risk of osteoporosis, and particularly for much younger women in their menopause transition, particularly under the age of 40, there is evidence to show that HRT reduces the risk of dementia and Parkinson's disease. So hopefully I've shown you that, you know, menopause care is really individualized. There are so many different options, and it's really unlikely that there's just a single way forward. And I believe the important thing is for women to understand, you know, have the understanding of all the different ways of helping symptoms, understanding the risks, understanding the benefits, to make their own decision going forward, so women are able to function, so women aren't leaving their jobs, and women are able able to ask for the support that they need to help reduce the impact of those symptoms. And I know Helen now is going to talk more about menopause in the workplace and practical changes that can be made.
Brilliant. Thank you very much, Claire, for really demystifying the menopause. And before I go on to talk about work, because we've had a couple of work-related questions come up, which I'll pick up as we go through. There's a great question here for you around HRT, Claire. If a woman takes HRT, does that mean that she'll have periods or monthly bleeding?
Okay. So if it was within 1 year of your last period when you start HRT, you do need to take the type of HRT where you do continue to have a bleed for up to 5 years or until you're 55, which is when the vast majority of women's periods have stopped. And then at that point, you switch to the type of HRT where you don't have a bleed. If it was more than a year or almost a year when you started HRT from your last period, then you don't have to have that bleed HRT. You can have a no bleed HRT, so you don't necessarily have to have your periods back. If you are still having periods and you really don't want to, if you consider having a Mirena coil fit, for the vast majority of women, that will stop periods. So that's one way round the having to bleed if your periods haven't stopped. Brilliant.
Thank you so much, Claire. So just in the last few minutes of the presentation, so as Michelle said at the top, there's still a long way to go. There's been a huge amount of media coverage over the last year, but I think sometimes it's important to remind ourselves that there can be a bit of an echo chamber where we're talking to ourselves. There's a lot more work to get the conversation to cut through across the country. And if we look at the really much more well-developed policies that we have around maternity leave, around paternity leave, and so on, there's still a way to go. And as Michelle also said, there has been so much coverage about menopause over the last year. We're seeing data around women leaving the workplace. We're seeing people looking for petitions to be signed for every company to introduce a menopause policy. As Michelle mentioned, we're seeing women taking their employers to tribunal and winning. We saw the Committee for Equality, the Women's Equality Committee, do a call for evidence around menopause last summer. We had a webinar earlier on this year. Dr. Claire and Caroline Noakes and some others, and Caroline Noakes, the MP who chairs that committee, said that basically her view was that menopause would become a protected characteristic, again, giving more protection to people going through it. And it's really important because, again, it's not a niche issue. There are around 4.3 million women aged 50 to 65 in the workplace, and many of them are in senior roles. And arguably, whether you're in a senior role or not, for many women, being in the workplace is an economic necessity. It provides them with independence. It enables them to live the lives they want. It can, for many others, it can provide, psychological, emotional fulfillment as well. And really importantly, women have such an important contribution to make to society at home and in the workplace, that it's a tragedy and it's a travesty when we think about how these symptoms, which as Claire has outlined, can be managed. You can't take control of them. When they're not managed and women aren't giving the right support in the right way, there are these consequences. So data from the British Menopause Society research showing that on average, women missed just over 3 days of work each year due to their symptoms. And that adds up to a potential productivity loss of around 14 million days in a year. Women aged 45 to 54 are the group to most commonly report work-related stress. And now that won't be all menopause related, but I'll bet you menopause is a significant contributor to that. Because again, we see that lots of organizations don't capture menopause symptoms separately when they're recording reasons for absence in many women. And so it can get captured under stress. And many women, if they're not comfortable speaking about their symptoms or saying that they're due to menopause, they'll call it stress as well. And there's the invisible impact that we've all discussed. So there's lots of data now out there that suggests that menopause symptoms are the reason that almost 1 million women have left their jobs, while others have reduced their working hours, considered not putting themselves for promotion or changing their jobs to better deal with their symptoms. And we've just got a couple of quotes from some qualitative work that we did, just to really put some emotion behind these hard facts and stats. These are real consequences. So one woman who worked in a more male-dominated environment said that, you know, if she discussed her symptoms of what she was going through, it would be seen as a sign of weakness, and she didn't want to give that, you know, that impression. Another whose colleague took a demotion at work. Again, it really doesn't have to be this way. And if we look at the gender pay gap here, we can see that over the last, you know, decade or so, couple of decades, we've really narrowed the gender pay gap for women in younger age groups, so 18 to 39. But if we look at older women, so from 40 on, we can see the gender pay gap is still way too high. And menopause and the reasons I've just outlined will be a key reason for that. And it's so important for equality in society that we close this gender pay gap and we close the pension pay gap. And again, menopause will be a driver of the pension pay gap that we're seeing for women as well. And I know as a union, you will be campaigning really hard for that. That's why if we want to get to the root cause of some of these issues, we've got to look at what's causing the gender pay gap and the pension pay gap, and tackling menopause and giving more support is definitely going to help. So hopefully, as you can see with all of that, the menopause is a business issue and it's not just a woman's one. And if we think about, and I know there's a couple of questions here on that, different ways to support women through menopause at work. And it really is about taking an integrated approach. We'd always start with culture. It's so important to create an inclusive culture. And there are lots of different ways to do that. And we're talking about an age inclusive culture here. So developing a menopause policy can be incredibly helpful because it gives you very clear guidelines about what as an employee, the type of support you can expect, what as a line manager is your role, and what kind of support you can offer to your colleagues. Raising awareness, so sessions like we're doing now, workshops like we're doing now, and Claire and I do lots of these. Thankfully, more and more organisations are seeing the need for it, to raise awareness of what the menopause is. It can be hard for people to have a conversation about menopause if they don't understand what it is. So raising awareness, educating, sharing factual knowledge and information, signposting to resources, and really importantly, normalising the conversation. Top-down leadership is key. And I know Francis had a question around what's the best way to deal with employers and look at examples of successful negotiations and best practice. And there's another suggestion around how to encourage discussion of menopause in workplaces, and definitely menopause cafes kind of bottom up, but top down is really important. That tone from the top is hugely important. Training can be incredibly helpful to help managers understand the workplace adjustments that can and should be made, because it might vary by organisation. Within big organisations, it might vary depending on whether you're on the shop floor, the factory floor, or whether you're in a support office. And training managers to understand how they can manage performance proactively and positively as well. And then supporting colleagues with access to specialist menopause services and advice. Again, we're seeing the pressure that the NHS is under. So women aren't always getting the care that they need from their GPs. GPs are massively stretched as well. So that extra support can be incredibly helpful. So we've got this deck that we'll be sending out, and we'll share a whole range of resources from everything from the Chartered Institute for Personnel and Development to our own website, to the British Menopause Society. But I think that, Michelle, concludes the presentation. So I'm going to come off sharing the presentation and hand back to you.
That's great. Thank you so much, Helen and Claire. I have to say, even after being at your training session not very long ago, all of that content just doesn't fail to have a massive impact. I mean, it's so informative, and I'm sure that there are people on this call who are having their own little light bulb moments about piecing together, you know, different experiences that they've had or they know their colleagues have had. And it's far too easy to see things in isolation, in a silo, without kind of putting that bigger picture of symptoms or experiences together. And I know there's a couple of more questions here, and I think it would be helpful perhaps maybe for Claire to pick up on a couple of them that are maybe more aimed at the medical advice and guidance that's out there. And I think you touched upon the NHS being kind of under strain, and it really strikes me how poor the quality of quite a lot of kind of medical support and input that a lot of our members who've spoken to me about their own experiences have had. And the seismic change, Claire, that you said, you know, you can see is growing. It's there. Do you feel that that's filtering through to the kind of, you know, level of primary care? So at a GP setting, that more GPs are becoming up to speed and trained and able to kind of look at what some of these symptoms are like. I think particularly for perimenopausal women who themselves aren't necessarily clicking and thinking, actually, could this be the menopause, because they're not really thinking that they're at that stage yet themselves.
Yeah, no, great question. I do think there's a massive way to go. So traditionally, GP education didn't include the menopause as a compulsory part for GP trainees. I know that that's now changed. It's on the curriculum and it is filtering through to GPs. So usually within a practice, there will be stressing the usually 1 or 2 GPs who have an interest in the menopause, but it's definitely not universal. Primary care is under pressure. It's difficult to get an appointment. If you do get an appointment, it's only 10 minutes long. That's usually, I would say, not enough time to have a proper discussion about options. I think you're right about pulling out the perimenopause, which is why I spent a bit of time sort of highlighting the fact that symptoms can start, because often women won't realise. They'll just think that they're just a bit frazzled or stressed and won't recognise symptoms as being related to the perimenopause, which is one of the reasons we wrote our questionnaire, which is on our website, to really help try and identify what's going on. So I think in summary, it's changing. We're not there yet. There's more work to be done. It's great, though, that women themselves are becoming more empowered to go and ask for what they want and challenge. I'm hearing that far more as well, if they're not given what they think. But there is a way to go. I'm not going to pretend there's not. Yeah, absolutely.
Which makes those workplace kind of conversations and awareness raising even more important when there's a clear gap in provision and awareness at the medical side in primary care. There's a couple of specific kind of questions that you might be able to shed some light on. There's an attendee who mentions that they were recently told by an MP involved in the menopause campaign that GPs are already allowed to prescribe HRT for a whole year on the one prescription, but their GP is only giving a month at a time. Is that the case? What is the flexibility there? Rachel also comes in with a question about which is both industrial as well as medical, I suppose, but you know, somebody who's got other conditions, so she's got the you know, menopause symptoms as well as endometriosis, inevitably create more sick leave here and there than she might like, but her work is almost triggering that through the absence policy and a suggestion of seeing occupational health. What would your thoughts be about that? Perhaps those 2 questions.
Yeah, okay. So in terms of length of prescription, so there isn't a sort of official limit on HRT prescribing, and we do often prescribe the pill for a whole year, so you could potentially prescribe HRT for a whole year for somebody who was very stable and was very sure they weren't going to change their dose. There is no reason why the GP is only giving it a month at a time, and I would say go back and challenge that. And that's so expensive if you're paying 2 prescription charges per month. Often it may reflect the GP's anxiety, and it will often not be for any very good medical reason. So I would go back and ask. I have to say, with the current supply issues, I myself haven't been prescribing a year at a time. We have had advice to just maybe give 3 months at a time, just so you're not giving a pharmacy's complete supply of patches, say, to one person. So I know that's a bit more of an altruistic, that's another issue. But there is no good reason why they can't give longer prescriptions. In terms, so many medical issues do get worse in the perimenopause. I think that's one thing to say. So if you suffer from mental health difficulties, they can worsen in the menopause transition. Premenstrual syndrome can get deeper and darker in the menopause transition. endometriosis. Endometriosis can, on a hopeful note, often improve as women go through the menopause, as the levels of hormones that are feeding the endometriosis decrease. Suggestion of seeing occupational health. So you don't want to stigmatize people needing time off for the menopause. You know, if it's needed, it shouldn't be an issue. Could there be positives in going to see occupational health? Often occupational health therapists are the key to many different therapies that you may actually get easier access to than you can through primary care. And think particularly counselling, etc. I know that's not really relevant to this question. So I think my thoughts are, you know, if you need support wherever you can get it from. If you need time off sick, you need time off sick. But I'd be interested to go back to your work and ask what their menopause policy is, and just see if there's provision within that for any other allowance without maybe needing sick leave. I don't know. Helen, would you have any thoughts on that yourself?
I think in many of the very progressive companies that we work with, they have excellent occupational health departments where they are genuinely there to support and to help. And I guess the thing is, that's not necessarily the case everywhere. And I don't know if that's, so I think there's in an ideal world, of course you would, but I think there's the understanding of, in a culture, in an organization, being really realistic, how stigmatized or not you would potentially be. Because we're on a journey and different companies are at different stages of the journey. But I agree with everything. In an ideal world, yes, you would ask for that support. It shouldn't be stigmatized if you need to take time off because of your symptoms. And I would agree with everything you said, Claire, about looking to see what policies and support is in place. But I think only you will know when you're in an organization what that culture is and what the type of support is behind it. And that's part of what we've got to change, though, so that no one is second guessing what their occupational health team are going to do with the information.
Absolutely, and actually that also represents an opportunity. If individuals are having those issues, it's probably the time, if you're in a workplace with NUJ organisation, to make sure your chapel is taking that on as a collective issue. And if there isn't a policy, it's a brilliant way to start the conversations that perhaps spark getting one off the ground, and those positive questions back to an employer. Do you have a policy? What is the provision for extra time off that isn't treated as usual sick leave? You know, it will flush out some of the gaps that perhaps exist, and negotiations about putting in some positive awareness raising and some positive changes to that particular workplace. And Anne mentions about for freelancers as well. I think we're very conscious as a union, you know, that our industry is very casualised as well. So it's very important for us that employers, and I know you train quite a lot of employers as well, is that they're actually thinking of their whole kind of team of people, whether they're employed, whether they're freelance contributors, opening up those workplace sessions, whether it's training courses, webinars or other materials that they have, making sure that everybody can have equal access to those is very important to us. There is, I'm just conscious of the time, but there is a couple of other questions. Somebody's mentioned licorice. So Claire, I don't know whether you've got any thoughts on licorice. This is in relation to vaginal skin thinning, and the person saying that they discovered that eating 100% licorice stopped that painful symptom. Is it safe to take long term?
Okay, so vaginal skin thinning specifically I alluded to in the sort of vaginal symptoms. So skin thinning, loss of elasticity, the skin can become itchy, more vascular, more sensitive. And so this is as a result of loss of estrogen on that tissue. So the best way of going about treating it is actually to use a vaginal estrogen, which has no risk of breast cancer, blood clots, heart disease. The vast majority of women can use a vaginal estrogen in a pessary or a cream or a gel, and that can be prescribed through your GP. I have to say, I haven't read about licorice as a way of helping, but doesn't mean to say it doesn't. You do have to be a tiny bit careful with licorice, because I happen to know that it can push your potassium up if you eat loads of it. So if you were, for example, on a blood pressure tablet that was going to push your potassium up, if you have a medical condition which affects your kidney function, you might have to be a bit careful. And you might want to speak to your GP about using a vaginal estrogen.
That's great. Thank you so much. There's also, well, advice about raising awareness and providing support for peri and menopausal women in chapels. I think that also comes down to information, doesn't it? Kind of bridging that knowledge gap, and a session like this is absolutely something that anybody on this call go back to their own employers or employers that they engagers that they have links with and say, what do you have in place? There's this great kind of webinar out there. There are lots of other organisations also offering similar and different resources. Can we get something off the ground, and something that we can encourage a lot of people to come along to, or have as a webinar that can be accessed at different times? And I think that's a brilliant starting point of having those conversations and encouraging people to talk to each other as well. So I think Natasha's point earlier about the menopause cafes, and Helen, you saying that grassroots up work is as important as the top down tone, and hopefully with a combination of that effort, it really starts to make a difference to that cultural vibe in any organisation, and make it somewhere that people feel that they can access support and ask. Some of the questions, I know you touched on, Helen, they kind of relate to some, because there's some really basic things that could be put in place as changes that would make a difference. And temperature was mentioned. Obviously, there's wars in most newsrooms or organisations about who controls the temperature in any office, whether or not you're perimenopausal or menopausal or what. It's a subject of great debate. But presumably something as simple as a fan, something as simple as changing temperature controls can actually really make an impact.
Yeah, the newer offices actually allow for more zoned temperature control, believe it or not, because yeah, I've lived through those wars, you know, in my time at Boots as well. And this didn't have anything to do with menopause. It really was gender, which is so interesting. But there are other things. So having a fan, but I had an interesting conversation recently about not just having the fan for menopausal women, because then it goes, there's the menopausal woman. Let's give her a fan. So just kind of making them more generally available. But it could be like sanitary products, you know, period products, and toilets, you know, providing more breaks if you don't have the flexibility to schedule your own breaks and stuff. So there's some really great examples of best practice out there. So, and if you look at the Chartered Institute for Personnel and Development and the website HENPEC, Menopause in the Workplace, they have brilliant advice on there for specific things you can do.
That's great, and I think that speaks to some of the comments people are making about ending the stigma. You know, unfortunately, there is still a stigma in too many workplaces. So something as simple as that, making sure that the fans are there for everybody, is a really easy solution in that regard. We're about to wind up, but I just wanted to read out a comment that Siobhan's made in the box as well, which is just to say that I wish your talk and these discussions had been more commonplace a few decades ago. This webinar was so valuable, thank you. And I think it really was, really meaty, lots of information and materials there that I know our members and our reps can really use to make a difference in the workplaces that they're in. So thank you so much, Helen, and thank you, Claire, and thank you to everybody who's joined us today for this lunchtime session. We have recorded it, so we are going to make it available to our chapel reps, who are the workplace organisation of the NUJ, and to our wider membership, so that people can hook in and have the benefit of this session as well at a time that suits them. So thank you so much, everybody, and thank you everybody for coming along, and do keep an eye on the other materials that the NUJ makes available on its website as well. Thank you. Bye.